Okay, welcome back everyone who was with us for our first session. Moving on to session 2. It was pointed out I failed to introduce myself the first time. My name is Sean. I'm one of the EMS conference committee people doing your IT and leading through today. So I'm just going to do the same announcements I did before the last session. I'll do these again. If you are an agency and there's multiple folks viewing this, please complete your own training roster for your agency for the multiple folks signed in on a single account. For those that might be having audio issues occasionally, recordings of this will go onto our YouTube channel afterwards. The most common cause of audio issues is a poor bandwidth on your end, so make sure you don't have multiple links or screens open at one time. That's usually the issue. For those who are signed in and registered, you will automatically get a certificate of attendance from the website. On that, it shows the State of Oregon CEU category that this applies to. If you have any questions as we go through here, you can either shoot them to us on Facebook Messenger or put them in the chat or question box. There should be somewhere on the right-hand side of your screen. If you want to get that box out of your way while you're trying to watch this, there's a red arrow pointed to the right. Just click on that and that will minimize the box. You can then click on that again to open it back up. Don't forget to sign up for other sessions. There's one more session this afternoon that starts at 15:30, and then we come back to you tomorrow morning, bright and early at 8 o'clock. And again, if you have any audio issues, just make sure you have things closed and that you have the right input coming out on that. So that being said, we are ready to go with Mr. Chris Ebright again with session number 2. And Chris, it is all yours.
Okay. Well, welcome back, those of you that were in the first session, or if not, welcome. And just a little bit about myself, if you hadn't heard. My name is Chris Ebright. I am a EMS educator with ProMedica Air and Mobile up here in Toledo, Ohio, which is a helicopter and ground-based critical care service that's hospital-based here in Toledo, Ohio. And I've been a paramedic now for going on 26 years and been teaching for EMS for about 25, and had the privilege of coming out to your conference a while back, and unfortunately we couldn't do it this year, so we've got the next best thing. And hopefully next year, if I so get invited back, then hopefully we'll see you all in person and we can swap stories and have a lot of fun. So hopefully you'll enjoy a little bit of this and get something out of it. It's something that you don't see a lot of, but in the pediatric population, it's something that's a little bit more likely to occur, and it's a phenomenon which is called commotio cordis. That being said, what is it? Well, that's the whole thing. We're going to kind of explain throughout the next hour what it is and what to look for, and then some of the scenarios that you may find yourself in where this is possibly the underlying mechanism. Regardless of the fact, if you're called for this, the common call is going to be for cardiac arrest. And you hear the 3 magic words, pediatric cardiac arrest. And I can't speak for yourself, but I would imagine a lot of us that are listening out there, our sphincter tone gets a little bit tighter just when we start to hear those things. And, you know, rightly so. I mean, we don't come across pediatric arrest very often, thank goodness. When we do, unfortunately, they don't go very well because, again, it doesn't come down to anything that we're doing wrong. The problem is the response time. You know, obviously something has to happen. Someone's got to figure it out. Someone calls dispatch. Dispatch calls us. We get in the truck. We go. We get there. And if nothing's been done for this child in that 10 minutes or so when they first go down, the likelihood you're going to get a resuscitation is very, very minimal. And so the good thing about this particular incident that we're going to talk about, in most cases, not every single one, unfortunately, but in most cases, these kids are resuscitated because they happen usually at some type of an event, whether it's a baseball game or a judo match or whatever. I mean, someplace where the child obviously has been playing a team sport of some sort, usually, and there's lots of people there. So even if there's not a defibrillator nearby, like an AED, which in a lot of cases there is, at least in the crowd, there is typically someone there that is versed in CPR. And they're doing something that's buying you the time to get there and or the time for that defibrillator to be applied, because these kids typically go into ventricular fibrillation cardiac arrest, which is another thing that we, especially as advanced providers, know that hardly ever happens. kids are very predictable. When they arrest, they go tachycardic, they go bradycardic, and then they stop. Just asystole, and that's it. We don't see ventricular fibrillation with kids very often. We see it all the time with adults. This is one of those instances where you're likely to find it. And when that AED is applied, it's going to recommend a shock. So we're going to talk about the mechanism of how that actually happens, talk a little bit about electricity and how it actually is generated. And on top of that, the necessary means as far as treatment, especially at the BLS level. Those of you that are listening here that are BLS providers, quite honestly, you can probably do just as much or more for these patients than most of your ALS providers that are listening as well. The only difference between us and you is that, well, we've got a few more toys to play with and a couple of drugs. BLS is going to save these kids. BLS does wonders for kids, and these kids react to it very well because the majority of them, they got good pipes, they got good pumps, don't have a lot of disease processes, don't have a lot of medical history. So if we can get to them soon enough, the result is likely to be much better than what would be in the same instance with an adult. All right. So the incident that gets called in, as I said, is a cardiac arrest. And it'll be explained 100 different ways. But in most roundabout scenarios, it was the child gets struck, they take a couple of steps, perhaps, and then within a matter of seconds after being hit, they just collapse and they don't have a pulse. Okay? So in essence, it is cardiac arrest. Now, most definitions apply cardiac arrest to being sudden cardiac arrest or sudden death is onset of symptoms all the way up to an hour later. If they're still in that range and they had signs and symptoms of chest pain, okay, and then they arrest, that's considered sudden death. So what you've got here in these children is not a heart attack per se. It's not a coronary artery issue. It's not myocardial damage. It's literally the heart's just been kind of stunned and doesn't know what to do. So it just sits there just like a bowl of jello and just shakes because it doesn't know any better. All right. These patients, as I said, they get hit, they stumble, they go down, and they don't wake up. And these are school age kids, up through adolescence that we would never suspect this happening. And they're otherwise healthy as well. Okay. So as I say, people will tell you different scenarios and they think, oh, maybe the child had a heart attack or something like that. It's not. It is totally something else. Now, I say that only with an asterisk because, yes, there are children out there that are playing sports, that are doing activities that, yes, have congenital issues. But the majority, like I say, 99% of the kids that have this happen to them, that's not the case. All right. So when we start looking at, these kids, the numbers are probably about the same. This statistic's a little bit old. It's about a year or two old now. But over 7,000 kids less than 18 years old experience sudden cardiac arrest each year. Some of them, like I say, have congenital issues. Some it's because of this. And so they go into this cardiac arrest registry. There's a registry for this. And they kind of get lumped in with the congenital kids as well as the commotio cordis type of incidents. So behind it, why is it that these kids go into sudden cardiac arrest? Well, as I said, one thing is that they've got a cardiomyopathy of some sort, either restrictive, hypertrophy, something where, again, genetically it is an alteration of their myocardial mass that causes them to have problems. Another possibility is that they do have an inherent issue with their electrical system. Now, sometimes that's controlled by medications. Sometimes it's controlled with just other regular therapies. Sometimes these kids have pacemakers. So that may be part of the problem is that you have a child that maybe does get struck or they're in an accident, let's say, and it causes their pacemaker wire to detach or, in the pacemaker itself, the body of the pacemaker is what's called the can. The wire comes loose from that, or there's direct damage to the pacemaker itself, or the battery fails, So that may manifest as your sudden cardiac arrest with these children sometimes, which, again, there's not much we can do in that instance because we obviously can't repair the pacemaker. Sometimes they develop an infection. And unfortunately, the cases of myocarditis among other things, have risen over the last 5 to 10 years. And it's become more of a problem than what it used to for some reason. Now, we throw in this whole COVID thing that we've been going through for the last year that has kind of increased the numbers as well. They don't really know exactly why that COVID-19 can cause myocarditis in kids, but it can. And the problem is that when they develop this, it causes an inflammation of the myocardium, which as a result decreases its ability to pump. Thus, they have output issues. They can't control it with their rate increase, and their blood pressure drops, and eventually they start having perfusion problems that can be fatal. Um, the difference is that the cardiomyopathies and those things are well known. They're genetic. Okay, they're already inherent. The abnormalities in the heart electrical system have been usually detected to some sort, or there's direct evidence like a pacemaker. The itises of some sort is just that. If someone has an itis, it's an inflammation, irritation, infection. It takes time to set up shop. So there may be something when you're able to gather a history with these particular patients that the caregivers will tell you that the child's been progressively feeling worse the last couple of days. Myocarditis, especially in kids, manifests itself almost like the flu, almost identical in its early stages. And to tell the difference is darn near impossible. But the same story will be there. They've maybe had a temp, they've been getting sicker progressively over the last couple of days, and now all of a sudden this happens, right? So cardiac wise, any one of those can lead to a sudden cardiac arrest in these kids. Outside of the commotio cordis that we're talking about here, there aren't many other external causes. So meaning strike to the chest or something like that. All right. One of the other internal issues that we look at as far as cardiac related per se, and this is again going back to the electrical system to a certain degree, is that they have this. They have an inherent issue which is called long QT syndrome. Now, a lot of kids don't know they have it because their heart pumps just fine. Even under stress, they're resilient. They don't get symptomatic. They don't have a problem, right? But in certain instances, if this is there and something happens that causes an exacerbation of this, the child will collapse and they'll go into cardiac arrest. So I'm trying to explain a little bit of the mechanism behind that here, just for a bit. How do they get it? Again, this is another genetically transmitted type of issue, if you will. It's a chromosomal disorder that causes a change in the channels of the electrolytes that go through the muscle and make it actually fire the nerves, right? So typically it gets passed down from generation to generation. So first relatives, so mom passes it to their child, dad passes it to their child. It doesn't tend to skip, right? So it's like, well, grandpa had it, but then, mom and dad didn't get it, but yet now all of a sudden junior gets it. It's usually, again, firsthand relatives that have had it. But there are a lot of parents that realize they don't have it either. So that sometimes never comes up. Another one that's likely to cause it, especially the kids that get sick all the time or kids that have other medical issues, is that they're taking medications that can just, as a side effect, naturally prolong the QT interval. I'm going to talk about what that is here in just a second and why it's important. And this stuff that's over the counter, not necessarily a prescription. It's just as much over the counter. Excuse me. And in this instance, if you were to Google long QT syndrome medications or something similar to that, you're going to get a list of like 500 different medications. I mean, it's just ridiculous. And a lot of them you've either taken or you've probably given to your kids. Not to say that it's caused a problem, but it can. It's just part of the side effects of it. The last thing is if they have the electrolyte imbalance. That can also prolong a QT interval simply by their absence. So especially potassium, magnesium, and calcium, those things can be thrown off very easily, especially with your undercover kids that are having issues with anorexia or bulimia. They hide it very well because they're kids. They're able to do that. And so the parents don't pick up on it. There's no, history of mental disorder, so to speak, in the family that's been known. It's just something that maybe it's happening, and unfortunately, it gets to a point where now all of a sudden the child suffers because of that binging and purging or not eating at all or whatever it might be, and their electrolytes are low enough that it causes a repolarization or a depolarization issue in their electrical system, and it throws them into a chaotic rhythm, which now we're presented with. But the whole thing is like, well, what's the big deal about the QT interval? Because it's like, okay, I've heard about it, I know what it is kind of, but so what? Well, here it is. And what it's representing is the time when the ventricles contract and then fully relax, right? And that electrically is demonstrated on a EKG. Those of you that don't necessarily run EKGs all the time, so if you're at the basic or first responder level here, that QRS and T waves are part of that whole cardiac cycle that represent the ventricle, which is the QRS contracting, and then the T wave, which is relaxing of the ventricle. Now, the problem is that if this interval that you see here starts to lengthen out, so either the QRS gets wider, or the ST segment gets longer, or that T wave gets wider as well. The issue is that there's a delay. Okay? And typically, again, either genetically because of a channel issue where their electrolytes can't pass back and forth like they should, or it's an issue with the system itself where it's just not repolarizing because of electrolyte imbalances. So kids that have been throwing up, kids that have been having large amounts of diarrhea, or both for that matter, okay? They throw their levels off all the time. The kids that have been out playing in the heat, okay, and maybe got dehydrated, that can cause problems. And so it's a very benign type of mechanism that can lead to this. But regardless, when this starts to lengthen out, what it's representing is that it's taking more time for everything to get back to normal. Now, because of that, there is a vulnerable period in this cycle that you see here that normally is very, very small. However, if someone has an extension of this QT interval because of either genetics or some other type of outside influence, and this gets wider, that window that was very, very small now becomes much bigger as well. And what happens is that if there is any kind of a impact or extra beat that occurs because of an irritable heart or a hiccup in the electrical system, whatever it is, if it fires in that vulnerable period, it actually can kind of throw the whole system into chaos and cause that person to go, that child in this case, to go into ventricular fibrillation. So let me show you what that is. This is what normally should be occurring. And it's all a combination of sodium entering, okay, and then eventually calcium coming in, and then eventually potassium leaving. And that creates that QRS, which is the sodium entry, okay, but even more so, the gradual release of calcium into the cell and potassium out of that cell, which creates that T wave. And they do this in a very concentrated pattern that relies on certain channels to be open to allow these things to move back and forth across the cell membrane. If those channels are inadvertently opened in mass, which they shouldn't be, okay, that allows more of a electrolyte movement than what's normal. That's what usually screws up the system, and that's the extra stimulus, the extra little bit of energy, if you will, that either leaves or enters that cell, and as a result, causes chaos in the nervous system of the heart and causes the ventricular fibrillation. All right, so when we look at long QT, all right, it's basically there's three different forms of this. So they label them long QT 1, 2, or 3. Now, where they actually cause a problem, okay, going back, if you look at phase 0, remember that's sodium coming in a cell. 1 and 2 is where calcium kind of comes in the cell to produce a contraction, and then 3 to 4 is where potassium leaves the cell. Sodium is responsible for the contraction and what's called depolarization. So you squeeze the myocardium. All right. Calcium is what helps to enhance that contraction so it's forceful. Potassium leaving is what allows the heart to reset, relax, and eventually when you get to 4, then we start all over again. So they all have to happen at a certain time, in a certain concentration, with only a certain amount of channels that are open. But because of the fact that this long QT syndrome inadvertently opens channels when they shouldn't be, that's when you see certain things happen based on certain stimulus. So long QT1 happens typically where calcium has already come in the cell, but now you have a large amount of extra potassium channels open up that shouldn't or are open because of this problem here. And so that causes the problem here where it's just about ready to trickle out of the cell. Here you lose too much. This happens to be the most common one we come across because the mechanism behind it is usually pretty strenuous. All right, the second one happens a little bit later in the whole series of events. So when we're about to finish off that lack of potassium, when it's leaving the cell and basically resetting everything, that's where number 2 sets in. And number 3 has to do with the sodium channels, where it's a depolarization injury. This one is the one that we're called for and no one ever sees it coming. All right, so let me explain you the stimuli here. So long QT1 tends to happen typically, again, in that phase I told you about, just showed you there, where potassium's just starting to leave the cell, but calcium's finishing its entry so we can get a contraction. There's a really sticky period in there where you get those 2 electrolytes flipping back and forth. So if this person is doing any kind of strenuous activity and they have this as an underlying issue, certain amount of strain put on the system can cause that imbalance to occur and the electrical system goes haywire. One of the most common scenarios is that the child was swimming. Swimming, as some of you probably well know, is a very strenuous exercise. And even if they're not exerting themselves like they normally would in like a race, even just the normal mechanism of swimming, that's a problem. Now, that being said, when they arrest, now we've got a secondary problem. And what more than likely you're called for initially is that you called for a drowning, right? And sometimes the drowning exacerbates the problem, obviously, of them being in arrest. Sometimes they arrest before they drown. There's no way to tell, but usually in both cases, you've got the arrest scenario that you're dealing with. Long QT2, okay, which remember was when the potassium was just finishing off its job. So what happens here is that if that child were to be startled, so say they're on their computer, got their headphones on, mom or dad comes up behind them, taps them on the shoulder, and that's just startles them. They get that, epinephrine rush, or a loud noise or a bang or something like that. At the right point, that can cause that trigger to occur, and that would cause the problem, and they go into cardiac arrest that way. The third one is the one, like I say, where no one sees it coming. It's a sodium channel issue. So again, the actual depolarization, the actual contraction of the heart's affected here. And what happens is that the child goes to sleep, but then they never wake up. And they're found dead the next morning by the parents, the caregivers, whomever, and they were been dead probably for a long period of time. So they die in their sleep. Those are the ones out of the 3 that we're having probably the least likelihood of resuscitating. In that case, 1 and 2, it's about 50-50. Depends again on how soon we can get there. Now, that being said, what is this whole vulnerable period I was talking about? Because remember, those QT intervals that in this case is a genetic abnormality in this case. Why is that lengthened out? And what does it cause? Well, as I said, there's a vulnerable period in that QT interval that is always there with all of us, making a difference. Kids, adults, anywhere in between. But as the heart goes from contracting to relaxing, there's a small little space where there's, again, a movement of electrolytes that's not quite equal. Usually it's even going through certain stages, but here at this vulnerable period, it's not. And so because there's a slight mismanagement, if you will, of the concentration of sodium and potassium moving back and forth across that cell membrane, what happens is that now a blow to the chest or an irritable beat or something else occurs in that time period, those electrolytes basically stop shifting and the electrical system just cinches up. And when it does so, that's when the ventricular fibrillation is usually induced. So what you see is right there, okay? So that vulnerable window is usually on the upslope of that T wave. So just about at the beginning stages or halfway through the stage of that ventricle resetting and relaxing. That little window right there, about 15 milliseconds, is normal, and that's in all of us. When you take that QT interval and now we lengthen that out either genetically, okay, or by some other cardiac anomaly. Now that 15 milliseconds might be 30, 40, 50, who knows? But the longer that QT interval gets, the wider that window gets. So basically the bullseye on the back of their head gets bigger, okay? And so they're more vulnerable the longer that QT interval is. All right, so you may have children that have that inherent condition and not be aware of it. You might be that first person, or you might be with a medic and you read the top of that paper and you see that it's by definition too long. So what's too long? Well, typically with kids, when we look at a male versus female, males anything over 0.44 and females anything over 0.45. Anything longer than that, that's a long QT interval, which means that window's bigger, and that may be the root cause behind why they arrested, or you find it and they're fine, they need to be evaluated. Because if they are involved in sports, this is typically found in the physical in a lot of cases. Okay, this may be something that has to be addressed before they can be allowed to play. So regardless, with those triggers I told you about, that may be the cause behind the cardiac arrest. That also is that child that if they haven't been diagnosed, they've got this huge window. What I'm going to talk about next here makes this even more likely because there's a bigger window for that impact to occur into the chest, that it makes that more likely for them to arrest versus the typical child that has that smaller window. Okay? I'm not saying that it can't happen in the smaller window too, but it's not as obviously as likely with the child that has 15 seconds versus the child that has like 50 milliseconds, right? So in that, we get into what's called commotio cordis. And so in essence, what happens here is that the heart gets hit directly by an external force of some sort at a certain speed, right at a certain moment in that cardiac cycle, in that vulnerable window I just showed you, and it puts the whole electrical system into chaos. Okay? Kids that have underlying long QT, they're more likely to have this as a complication, but even kids without it, they can still have this occur, and it still does, right? And this is the basic presentation that you would get with these kids. They get a blow to the chest of some sort, okay? It's a blunt injury, it's not a penetration injury. The children, as I said, are normally very healthy otherwise, and they just take a couple steps and down they go. What you might pick up on is that bruise on the chest, and that's literally about it, if it's even there. But where it is also kind of helpful to make you suspicious of this just as much as if you don't see it. Regardless, the kid's in cardiac arrest. So we need to be doing BLS and obviously ALS as necessary. So that goes without saying. But seeing these things, okay, may also make you realize that this is a child that needs to be defibrillated as soon as possible, unlike your typical child that goes into asystole or some kind of PEA or something like that. All right. So the numbers, as I said, this is a couple of years old by now. I'd get in here and readjust these, I'm sure, but they're probably not that far off. 10 to 20 events are added to this registry every year. There may be more depending on geography and that kind of stuff. But just by itself, okay, this particular event is recorded at least, 20 times a year, give or take, out of the population, which you take the whole pediatric population, that's kind of a small number, but if you're a parent of one of those 20 kids, it's obviously a big deal. Third most frequent cause of sudden cardiac arrest in these athletes behind these two things. One is either a congenital anomaly, so maybe what happens with their blood vessels that their coronary artery on the left side actually ties, their left coronary artery feeds the right ventricle, and their right coronary artery feeds the left ventricle, so they're flipped. Okay? Sometimes there is an enlargement or an aneurysm of the coronary arteries because they have something called Kawasaki disease. Sometimes that's not congenital, but same thing can happen. The other thing is that they have the cardiomyopathy, as I told you earlier, whether it's, again, hypertrophy, whether it's restrictive, the muscle itself just doesn't squeeze as efficiently as it should. So this is number 3 behind those two right there. which both of those two are kind of rare. So this thus tends to be a little bit more demonstrative. All right. Now, when they first started doing this way back in the 70s and keeping track of it, survival wasn't that good. And a lot of it was because people were scooping and running. People didn't know what to do with a dead child, and they freaked out and they just stood there and stared at him, or combination of those things. Well, obviously now, with the proliferation that we've had with pediatrics in general through EMS, now what's happening is that we're doing good BLS. Okay? We're staying on scene longer. We're getting more people involved. We've got the whole pit crew mentality as far as compressions and so on and so forth. There are AEDs more readily available than what there used to be. Whether it's on scene or obviously one that's brought to the scene, they're effective in either regard because, like I say, most of these kids end up in VFib and it needs to be terminated as soon as possible. The advantage also, as I mentioned, is that most of these events occur somewhere in an arena or some other sporting type of event venue, or it's being monitored by the local squad members or whomever. And some of you have probably been to a lot of these games and stuff. You've got that equipment right there, and the downtime and the access to defibrillation is cut down, obviously, because of that. All right. So various sporting events, doesn't make any difference. But then there are other ones that it occurs outside of sporting events. And it can be that child that falls out of the tree and strikes their chest at the right time. It could be, the car accident, like I told you about, where they hit the dashboard or the belt or something like that, or something else occurs that allows for a compression at a certain amount of speed and force that's transmitted internally into the chest. The majority of them, obviously, about 75% of these cases, usually are, like I say, at a sporting event of some sort. So here are some of those other circumstances here, and some of them seem a little far-fetched, but some of you, this might be something that you've seen before. If a child gets kicked by a horse, there's probably some other issues going on here as well. Head injuries and other, trauma types related problems. But yeah, sure. I mean, it's enough force that it will obviously cause this to happen. Recoil from a gun, the auto, excuse me, the car accident that we talked about. Sometimes, again, at least around here, I'm sure you guys still have your snowpack out there. Ours is starting to melt because we're getting into the 50s finally this weekend. But flying, down a hill and all of a sudden, either you get airborne and hit something, or maybe just get hit by the sled. There's blunt trauma to the chest that happens that way. Hitting the handlebars, going, frontwards off the bicycle. All those various things are still possibilities that could generate enough force that could cause this problem, which is commotio cordis, right? But where I can say we normally see this is going to be some type of contact. It could be an individual sport, it could be a team sport. It doesn't make any difference. But the key is that the history is going to tell you, if you got a child in these events and they took a couple of steps, took a blow to the chest, and then collapsed, this is probably what you're dealing with. So we've got a cardiac arrest. It's more likely ventricular fibrillation in nature, and it can be terminated, and these kids can be resuscitated, but we've got to get on it as soon as possible. All right. So where you see the more common venues for this to happen, baseball tends to be the most common. And it's typically, as I'm going to tell you about, with the younger kids, among other things, their reaction time is much slower. Their anatomy is a little bit more conducive to allowing excessive force to get into the chest. And obviously, baseballs, even in the younger ages, they come at these kids pretty quick. Same thing with softball, hockey, getting either hit by the puck directly, but still getting elbowed, getting a stick to the chest, getting tossed into the boards, falling on the ice because they can't skate. Those are all possibilities that can lead to this as well. Football goes without saying. There's lots of different mechanisms there. And soccer, especially women's soccer. If you've never seen a women's soccer match, oh my God, okay, they are vicious. Taking an inadvertent, a kick or a knee or an elbow or something like that, okay, sometimes, again, that's all it would take. And then the other various ones like you see here, and we don't do too much cricket here in the United States, but yeah, but rugby, sure enough, that's starting to come around. Your karate, like I say, those are judo, where they're taking impacts, more karate than anything else. That can cause a problem too. All right, so here's a picture of a guy. He was playing lacrosse, and you can see on his chest there, he's got the ball there, and he's kind of pulling it up right about to where his impact was. And you can see the bruise there. He did suffer a commotion cordis event. He obviously was resuscitated and did survive. But you can see that he's still being monitored and will be for a little bit of time. Very small ball, high rate of speed, hit him just in the right spot at the right time. Even at his age, being an adolescent, don't throw this out of the realm of possibility. Yes, your younger kids than him are more likely, but even in this range, at the right spot, it can happen. This is the area that you start to be a little more suspicious. Anywhere near around about the apex of the heart. So again, give or take between the fourth and fifth ribs, okay, about mid clavicle on the left side. That would be, you'd see the bruise, or you get a painful area that you palpate. This is likely because what happens is that when this impact occurs, it's going to hit in that area right where the bundle branches go off to the ventricles. So for those of you that don't understand that, your electrical system goes through the septum of your ventricles, and then it branches off into the right and left ventricle. Well, where they take that turn to go to the ventricle is right at the tip of the heart, and then it goes right or left, depending on the side that we're talking about. So there's a lot of energy there, but if you disrupt that right at the point where it goes to both ventricles, you literally disrupt the electrical system that feeds and contracts the left and the right ventricle. So the apex is kind of the main area where we see a lot of these impacts occur, and that result is what we get because of those reasons. Now, why the kids? All right, well, here's why. One, like I say, their chest wall, their anatomy is a little bit more pliable. The younger they are, their ribs are more cartilage than they are calcified bone. And so, unlike the adults or your older adolescents that have the ribs that are intact and they're all pretty much ossified, things tend to bounce off the ribs versus a child. Those ribs would tend to cave in a little bit and bend, but it also allows then that energy to transfer into the chest a little bit more so than what it would be for an older patient. So that's problem A. Problem B is that they got the slower reflexes. And it's, not to be rude, I said, but you go to a little league baseball game or, even T-ball or something like that, and you watch these kids, it's just like a comedy of errors. They can't get the gloves up fast enough. The reflexes are slower because the brain doesn't get to the arms fast enough just because they're of their age. You see them running around the outfield trying to catch a fly ball, and three of them are all going at the same time. And that very well could lead to this event. They bump into each other, not paying attention, and they catch the elbow in the chest the right way, or who knows what. All of a sudden, the kid goes down, doesn't get back up. So reflexes have something to do with it, and just their chest in general. Your average child, okay, yes, there are very large children, obviously, but your average child is going to have less muscle mass and less fat that's there to absorb some of that shock. So they have a thinner mass, they have ribs that give, and they have slower reflexes, which just predispose them all to that possibility that traveling in the right direction at the right speed and hitting them at the right time, right? These kids get plunked in the chest and all of a sudden they go down and they don't get back up. So, as I said, there are a lot of cases where we do resuscitate them right away, but even with everything in place, unfortunately, sometimes that doesn't happen. And this is a typical scenario that you see here. He was 13 years old, so reflexes weren't bad, but still thin chest, okay, ribs that give, so on and so forth. And he was actually trying to bunt and took a pitched ball. Right? And at 13, they can throw with significant velocity in some cases. He inadvertently went to square up, got hit in the chest. As you can see there, he took a couple steps toward first base, collapsed, and that was it, and they could not resuscitate it. So the key is, well, then how fast does this thing have to be going to be a big deal? Well, when it hits, okay, what it does is that, among other things, it's not only hitting the heart and stunning the electrical system, but it's also stretching out the wall of the heart, and it's also causing the pressure as a result inside the ventricle to increase. And all three of those occur with the same mix. Eventually what will happen is it'll cause that system to short circuit. Okay, so let me show you how that works. So the speed on average, okay, is about 40 miles an hour. That's it. Now that seems like that's pretty fast, but like I say, your average little leaguer can throw easily 50, 60 miles an hour if they're, playing little league ball. Kids that run into each other may not be going that fast, but still, they impact at the right moment. You get older, like I say, baseball, getting punched, getting kicked, falling on something, going over a handlebar, all those inadvertent, accidental types of exposures still can be roughly about that same speed in general. So here's the deal. So we'll take baseball because that obviously is the most common reason why, or softball, same thing. The bigger ball, obviously, in softball, but either way, you've got a small circular shaped, very hard object that directly impacts right about, again, the apex of the heart, like you see here. And when it does so, here's the thing. So the pressure inside the ventricle initially rockets up because of the impact, okay, the squeeze, so to speak. The second thing is that area where the ribs are more flexible and the energy is transferred in there because there's thinner skin and less muscle, what it'll do is it'll hit that tissue and literally kind of spread it out. So on that last picture you see there, the channels, there are only a certain amount of channels that are open at one point. That's why I told you about potassium especially, and calcium and sodium. They're supposed to be open and closed at a certain point to allow the electrical signal to be efficient. If they all inadvertently open, or a vast majority that shouldn't be open, it throws too much of that electrolyte either in or out of the cell, and that causes a disruption, which screws up the electrical system. So that's what's happening here. That impact basically stretches out that portion of that wall of that ventricle, and when it does so, in a very split second, stretches that out, and in that stretch, it inadvertently opens up a bunch of channels that shouldn't be open. And more particularly in this case, it's potassium channel that gets widely spread open, and potassium literally just rushes out of the cell. And when that occurs, right, the muscle can't repolarize itself, it can't reset itself, the electrical system can't keep up with it, and for all intents and purposes, it's stunned, and you see the resultant rhythm that occurs. Now, when this occurs, it occurs in that vulnerable period. So I told you that most kids will have that 15 milliseconds, give or take. All right. So if this happens in your average child without any problems otherwise, this is that 1 in a million shot. All right. Kids will take blows to the chest all the time and never have a problem. But when they get hit in that vulnerable period, as I told you, sure enough, down they go. Now, let's take that child and we'll multiply the issue because they do have long QT syndrome, whether it's been diagnosed or not. Their window is much bigger. So they take the same hit, okay, in the same area, but now that window's a lot bigger, the likelihood is that you're going to have that vulnerable period be exposed. The likelihood is that they're more likely to go into cardiac arrest. Both of them go down, both have the same presentation. Obviously, one is just more likely to happen than the other. Okay, so just another example of it here. And this was something obviously was computer generated. This was not a patient of any means, but you can see where it happens is roughly right about on that upslope of that time, where again there's a slight imbalance in the electrical system from sodium and potassium, and this hit occurs right during that period. The potassium channels open in mass like they shouldn't, and because of that, it rushes out, causes a short circuit, if you will, of the electrical system, and then down they go, and they stay down. This isn't a transient thing where they'll come back. Once they hit this, unless we get rid of it, right, they're not going to come out of it. So the quicker they can be defibrillated, the better. Because here's a series of events that are going to occur once that child takes those couple of steps and then collapses, and they are in cardiac arrest. In this case, obviously in VFib or something similar to that. The problem is that in those first 4 minutes, right, the cardiac muscle is still shaking. Now, it's not pumping very well. It's just sitting there shivering like a bowl of jello, but it is still active, and it's burning up any oxygen or sugar that's in that local area, in that local tissue, and that blood supply while it's doing so. But in essence, again, it's not contracting, so blood's not leaving the chamber, and thus they're in that pulseless arrest. All right. Now, what'll start to happen after that 4 minutes is that the oxygen and the sugar basically gets burned up. Remember, kids' metabolism is much faster than an adult. So this time period may even be sooner in certain cases. But regardless, what happens is that now the muscle becomes inefficient because it starts having to work on burning fat or sugar, or not sugar, fat or protein, or living without oxygen. And it can't make a lot of energy. And so when that energy is not there, the muscle doesn't have anything to use to make itself fire. So the muscle becomes even more ischemic. The muscle eventually stops shaking altogether, and they do go into asystole. But then this is the patient that once we get to that asystole point, because they've used up all their energy, they can't manufacture anymore. Okay? Now cells start to die, get enough muscle mass in that myocardium of that child that dies, there's no coming back. And so that's why we're always so concerned about this whole 10 minutes, give or take with any cardiac arrest, but especially with kids, because obviously when they're younger, their hearts are smaller, which means there's less mass. And so even a quarter of their mass would kill them versus us. We could be resuscitated, but we'd obviously have issues, and the patient would have had CHF for the rest of their life. Kids can't tolerate that. So when they have this incident occur, luckily, as I said, it occurs where a defibrillator usually is somewhat nearby, and that's what's going to save them. So as you can see, with roughly about every minute that goes by, they lose about 10% survivability. Now, surviving and resuscitation are two different things. Right? When a child's resuscitated, that means we got a heartbeat back. Maybe they start breathing, but at least we got the heartbeat back. Now, we may not be able to detect that right away, but if you put them on the carbon dioxide, obviously the result that's coming back, you're going to see that spike. Okay? I'll show you an example of that here in just a second. But that's going to tell you that at least their heart's restarted. We can support their breathing, it's no big deal. The further this goes, and again, that first 4 minutes, they've lost about 50% ability to survive the incident, which means is that they walk out of the hospital, right? More than that, obviously the odds just get worse and worse. Kids in general don't go into cardiac arrest, and when they do, the catastrophic events that occur chemically that I just explained to you become much more detrimental, much quicker, and thus makes it harder for us to resuscitate them, not to mention have them survive. So the key is good BLS. Hopefully, if you're not the person there, someone started something before you got there. And in a lot of cases, because of the venue, it's likely. Doesn't always happen, but it's likely. Good BLS is going to save these kids. Get them circulating, get them oxygenated as best as possible. And then again, once you get there, if someone is doing CPR, we're going to check the effectiveness of it, because not only is it the compression, it's also the recoil. That's just as important to allow the heart to refill. If you're doing it, it's a kid, right? And whether it's you or your partner or whomever, because it's a child, unconsciously, we just are a little bit more jacked up than what we should be, and rightly so. And even though we're doing what we're supposed to be doing, we can be compressing that chest a little bit harder than we should be. We could be compressing a little bit faster than what we should be, and we're probably not letting it come up as well as we should be. So check your partner, right? Check your compressions. Make sure that those are being done well. Now, how we can also tell that the rate's effective is that obviously you look at the CO2, it should be in a pulseless patient somewhere we maintain between 10 and 20. If it's less than 10, the likelihood is either your partner's getting tired or they're jackhammering too hard on that chest and not allowing it to refill. So check it, fix it. It's very easy to fix, and you'll see a change for the positive pretty much almost instantaneously. All right, so how long do we go? We keep going until either A, you get that spike in the CO2, B, that plus they start breathing on their own, they start moving around, and or they yell at you, just stop pushing on my chest. The Mr. Obvious one, right? And you'll be surprised. There'll be a lot of times where you won't even get into this part of the resuscitation, because if BLS was started before you show up, and if they were defibrillated before you show up, sometimes these kids are sitting up and talking and screaming and you never laid a hand on them, which is great. It's the prolonged ones that we're more concerned about. Where there wasn't a defibrillator present, we're concerned about. Where there wasn't any BLS being done, we're very concerned about in that case because of the time factor. But this would be something that, again, you might see even a more demonstrative spike in some cases where perhaps you've been privy to. But the top one is good compressions, and you can see with the ventilations there, they're around 10, 15-ish, somewhere on their CO2. But then you can see all of a sudden, bam, it spikes up almost to like 45 or 50, right? Out of nowhere like that, the ticker started. Because remember, even at our best, we're at about 33% effective compared to a normal beating heart. So once the heart gets going, it picks up that extra CO2 that's been sitting in the venous system that we couldn't circulate, shoves it all in the lungs, and then when they start spewing it out. Once they do, we pick up on it, we're good to go. So maybe at that point, you're just going to support their ventilations, or even better, they start breathing on their own, and yahoo, right? So let's give you an example of how this scenario might play out, right? So you're called for a 13-year-old, not the same 13-year-old I showed you earlier, 13-year-old that was found in cardiac arrest following a blow to the chest. Didn't really say how it happened, but obviously it did happen. And this could be something that's simply, again, a punch. It could be a hockey puck. It could be an elbow. It could be them falling onto something, whatever the case may be. But we're in the ER, and then the squad's about 10 minutes out, so they've already responded. And basically what happens in this case is that the patient was trying to catch a baseball. Inadvertently, again, got knocked into another teammate, caught the elbow, like I said. When that happened, he dropped to the ground and didn't get up. Fortunately, he wasn't just let to lay there like, okay, come on, get up, rub some dirt on and get back in the game type thing. Coach goes out, trainer goes out, sees that he's not obviously responsive and doesn't have a pulse. So they start BLS right away. So that's problem A solved right there. EMS showed up about 5 minutes after the fact, so relatively quick response time, fortunately. There was no AED applied, but they get their monitor on, and sure enough, they find the patient in VFib, which seems kind of odd for a 13-year-old. But VFib is VFib regardless. The mechanism makes sense now. So they hit him biphasic 200 joules, and the child comes out of VFib for two reasons. One, for the quick defibrillation within 5 minutes or so, give or take, of the arrest. But then second of all, the almost immediate BLS that was provided by the bystanders. Both played into the success of this working. Patient goes into a sinus rhythm, and now even starts waking up and is probably somewhat conscious before they even hit the hospital. So the ambulance shows up, and patient reports that they're saying, well, his chest hurts, mild anterior chest pain, nothing else going on, no shortness of breath, palpitations, weakness, confusion, any of that stuff that we would suspect normally with like an MI. He says he's got no history. Mom corroborates that story. He's never fainted or anything like that, never had any arrhythmias. Basically, again, the typical scenario with a clean bill of health, and this just happens suddenly out of nowhere in that typical type of patient. Okay, but the outcome is good. He survives. He was obviously almost completely resuscitated, or to the point before he even showed up to the ER. He was obviously taken for observation and watched, and the child walks out of the hospital and no harm done. So the question comes up is, because this happened once, is that child more susceptible to having it happen again because it did happen one time? And the answer is maybe. In certain cases, obviously, where it's the congenital underlying issue that caused this in the first place, yes, it is more likely, unless that child ever gets a transplant or just stops playing sports, which they may be told to do. They may obviously still try at some point or get into some kind of trouble or inadvertently get a shot to the chest from some other mechanism we've talked about. But usually, again, if it's the direct trauma incident that is the 1 in a million shot, could it happen again? Yes. Is it likely to happen? No. The kid with long QT is a little bit more likely, but then again, they're going to be advised more than likely in a lot of cases to not play sports or just not be allowed in some cases by the athletic association. Once they find this out, it's an automatic, you can't play. Not only for liability's sake, but just for the safety of the child. So some of it comes down to local issues, some of it comes down to common sense, some of it comes down to the parents. So those things vary. And, hopefully most of it, as much as we don't want the kids to be suppressed from playing sports for their own good, they just don't. But in certain cases, they still do. Sometimes it goes, like I say, it just goes undiscovered, and we're the first ones that are actually treating the result of it. But in either case, timely resuscitation and obviously defibrillation saves these kids, and hopefully that's usually more often the case than not. All right. So to wrap it up, again, just remember that most kids that collapse and go into cardiac arrest don't usually have underlying cardiac issues. If they do, it's usually well known. Most don't. Second thing is that the projectile speed or the punch or the kick or the impact into the chest is typically about 40 miles an hour, give or take. Can be a little bit less, obviously can be more, but if it's in that vulnerable period, the likelihood is that they're going to have that chaos ensue like we talked about, and they collapse. And then lastly, when they do, just about every single time, this is that child that's in ventricular fibrillation arrest, which is not typical for children at all. When we see that, they do respond to defibrillation very, very well. Once they're resuscitated, the after effects are minimal, if non-existent. There are no significant EKG changes. There are no significant laboratory changes that result. Thus, they need to be observed, obviously, when this occurs. And they just go back to living like they were, which is good. Outside of the other anomalies we talked about, most of these kids are fine, and they're sometimes clear to even go back to play sports, and they do just great. So that being said, take any questions that y'all might have out there. We've got a couple of minutes, and see what we can do.
All right. So one of the questions here, Chris, is there any age limit on long QT3?
No. 3 is just a number. Typically, again, they're already going to be born with it. Will they outgrow it? Probably not. They can have it modified medically through, again, chemistry basically, but the deficit's there regardless. And so because of that, they'll always be susceptible no matter what.
All right. Any other questions? That was the only question I had up in there.
Okay. And I told the other group, if you weren't in the first presentation, folks, if you want this presentation or if you got other questions, you go to bed tonight and something just keeps you up all night because you meant to ask me and you just forgot or couldn't think of what it was. My email is right there at the bottom, and my website's there at the top. Either way, you can contact me. Send me an email. I respond usually within 24 hours or less. Anything is a good question. There's never a bad question. So feel free to ask as many as you like if something comes up. Also, if you like this presentation, you're more than welcome to it. I see myself more as a facilitator as far as that goes. So if it works for you and it's something that you can use in your service or for yourself for a reference, you're more than welcome to it. Just let me know and we'll make sure you get it.
All right. Well, thank you, sir. We just put up in the chat window the link for the session that starts at 3:30, 15:30 for those of you following that time. And that link is in there. If there's no other questions, thank you, Chris, for your 2 presentations today and getting us started.
You're welcome. Glad to be here. Thanks for having me. Really appreciate it. And like I said, hopefully we'll see you all next year in person.
Perfect. Awesome. Well, everyone take a quick break. And for those coming back, we'll see you in about 15.